Welcome to today's HCEG webinar series. Let's give everybody just a minute to get signed on, and then we'll get started. Sue and Dr. DiLoreto, it looks like it's a minute after the top of the hour. I'm going to start our webinar. Welcome each of you who have joined, and thank you for taking the time out of a busy schedule to join this webinar series today. I'm Ferris Taylor, Director of the Healthcare Executive Group, and today's webinar is one in a series of webinars, this one discussing intelligent care management technology, driving alignment towards the triple aim. And we'll talk more about the triple aim and the technology that's there. Before we start, let me mention a couple of housekeeping things. First of all, everyone will be on mute. So throughout the presentation, feel free to click the Q&A button in GoToWebinar and submit questions. We will save some time at the end for the Q&A. In addition, the webinar is being recorded, and we'll send you a copy of the recording, the slides, and any reference resource material in the next few days. We're excited to have you join this webinar. Health plans are focused on proactive preventative care as opposed to reactive sick care that we've all been caught up in for some time. And technology is helping us seek targeted, proven, and personalized approaches to more managed care populations. We're fortunate to have Dr. DiLoreto, a principal at Vizient, SG2's consulting business, and Sue Powers, a longtime HCEG colleague. Welcome, Sue and Dr. DiLoreto. And Sue is also an executive with VirtualHealth. And they're here to help us discuss how intelligent care management technologies can help payer organizations to improve health outcomes, to reduce financial costs, enhance member engagement, and prioritize members' health, and empower care managers. So with that introduction, let me hand the first part of the presentation, Sue, over to you, and introduce yourself, and then when we get through your first part, we'll have Dr. DiLoreto introduce himself.
Sounds great. Thanks so much, Ferris. Really appreciate it, and hopefully everyone can see the slides and can hear me okay. As Ferris said, I'm with VirtualHealth. I'm Chief Growth Officer here at VirtualHealth, and I've been here over 5 years, and have been involved with HCEG for a number of years. Really love the organization and love the work that you're doing. So very excited to be able to participate in this webinar today, and looking forward to walking you through the presentation and then answering questions as we go. So what we really want to focus on today, as Ferris mentioned, is intelligent care management. I like to talk about it as proactive care management as well. And really what this means from an industry perspective, we've been seeing change in the healthcare industry, as I think everyone is well aware, over the last 18 months or so. Certainly with COVID impacting all our lives, things have changed, and organizations are looking at ways to improve health outcomes, to make sure that we're really on top of how members or patients are doing. And within the industry, one of the things that we've been seeing is the need for really focused data. And in this little diagram on the right-hand side, you see a point there that we like to talk about as health tech convergence singularity. What we mean by that is the situation that's really happened because of what's gone on with COVID, where we're at an inflection point where the need for bringing patient data, provider data, and payer data together through a single technology, where we can get more than 1 + 1 + 1 = 3, but even greater than that, because of that visibility into the continuum of care, and really seeing end to end what's happening with a specific member or patient, and how we can influence and improve their health outcome. So we believe that what's going to drive this and really add more value to what's needed in value-based care is this intelligent proactive care management technology. And couple this with some other things that are happening in the industry, it's around the demographics of the population. I think everyone's well aware, Medicare Advantage, that enrollment continues to climb and will climb as we get older. We are also seeing in the middle an interesting thing that we like to talk about as payviders. So it's really that bringing together of payers and providers around risk-based contracting, delegation of population, and moving away from fee-for-service. And you can see the bar graphs how that's really is declining as we move forward. Fee-for-service is getting less, where the pay-for-performance and the shared savings and capitation models are really rising. And those things require then a different type of care management solution, something that really is intelligence from the perspective of able to help the efficiency and productivity of the care team, as well as improving health outcomes at lower cost for the patients and the members. Of course, on the right-hand side, what we're showing there is the different cost ratios and what's been happening over the years in terms of Medicare funding, private health insurance, and then Medicaid. And so the pressure is on for the payers to really find ways to drive down costs while improving health outcomes. You know, big thing is keeping people out of the hospitals, keeping them at home, being able to heal at home, age in place, etc. All of those are important parts of this picture as we look to see how do we drive down costs and improve those outcomes. Now we turn to one of the industry experts, GARTNER, about their thoughts around the key criteria for what they're calling the next gen or generation 3 care management solutions. We said, what makes up technology? What is going to be the important features that make that up that will really capitalize and allow us to really attain that value-based care, that proactive care? And so they have a number of categories here. The first one is really around the different business models that any organization might have and the different goals that come out of those business models. It may be stars, it may be closing of gaps in care, it may be retention. But all of those specific business models, the technology needs to be able to handle that. So it needs to be a flexible technology that can basically move with the clients and based on what their models of care may be today and what they may be in the future. Also, the social determinants of health, those social needs, critical part of anyone's health outcome. There's different statistics on it, but the SDOH make up a significant part of indicators of when someone is going to be healthy and stay healthy. And so it's really important for that technology to be able to pull in not only the clinical information, but also that social need information. And I'll even extend it beyond there, beyond just the social needs, but also then the organizations in the community that can affect those social needs and proactively help them. Rather than reactive, make it proactive. The transition and facilitating those transition is, again, really, I think, key is from technology perspective is around flexibility and being able to change from a workflow perspective of how things need to transition as those models of care change and as people transition to more risk-based scenarios. Efficiency is obviously a key part. And what GARTNER points out is that really increased need for RPA, robotic process automation, as well as artificial intelligence. So really having a platform that is intelligent, that can look at different data and different events that are happening, and then determine how to drive that care team forward to make sure that they're really efficient. And then finally, the key part, and I think we all know this, is that the member or the patient has to be engaged and involved so that the member experience through this technology is key to making sure that they're an active part of that interdisciplinary care team that extends all the way out to them and making sure that we bring all the people into the picture, right, who need to affect that health outcome. So that's kind of how GARTNER has laid it out, and we at VirtualHealth agree with all of these things. We think that makes really good sense as far as what a platform like this needs to bring to the table. Another key thing, and we've touched upon it, but I think it's important to pull it out, is, again, data. And so having that full picture of the data from the patients, from the providers, and from the payers themselves, as well as from the community. And having all of that data on one platform so that the entire integrated care team can have access to it and can have a complete picture around the continuum of care and what needs to be happening in a proactive way as opposed to a reactive way. And so another critical part of this data is that it's delivered in real time, right? So that those decisions can be made at the appropriate time. We've mentioned this a little bit, but whole person care, right? Another key concept, because as I mentioned, those social needs have a big impact. So if you're only looking at clinical, you're only getting part of the picture. And I'll extend it even beyond that. The technology really needs to be able to handle all lines of business across an organization. And that can extend, beyond Medicare, Medicaid, and commercial, can be behavioral health. The organizations may have done that payer-provider integration and started actually with a health system, ACOs that come out of those organizations, as well as home care, and then, of course, the social resources. And the social resources, I really think is an important piece. Bringing in those CBOs, community business organizations that need to be part of the picture. And if the CBOs are brought into that technology platform and are able to contribute information in a closed loop manner, I think that we all are going to be much better off. And it takes us to this particular slide, which is really that focus on closed loop. The idea that we know when a member has been, sent to a social organization for some help with food insecurities or whatever it might be, that this technology can have the information coming back in real time to know that, in fact, that service was rendered, so that the care team has insight not only into the clinical side with care and case management, the physical health, information, but also the engagement by the member themselves through devices and hubs, as well as those community organizations. And then, of course, the workflow that brings that all together. So workflow that allows care management, case management, all to work together. So it's a seamless experience for the organization, and that workflow will help drive the care team as to what's the right thing to do for the right member at the right time. And that's done through, we think, the right technology. It's done through automation, or that RPA that I mentioned before, through leveraging business rules and associated workflow to make sure that in a proactive and timely way, you're driving the appropriate activities to be done, again, to improve those health outcomes. So that's kind of what I wanted to share, just at the high level about what we're seeing in the industry and what we're hearing from expert organizations such as GARTNER about what they think Gen 3 looks like and some of the components that make that up. And now, I'm very happy to hand off to Dr. David DiLoreto to give us his thoughts and insights about this topic.
Sue, thank you so much, and it's a pleasure to be with you today. As Ferris mentioned, I've worked with HCEG now for over a decade, and for 15 years prior to that, I've been actively involved in care management and in provider-owned health plans, as well as in large integrated delivery systems. So the evolution of the industry is what really came to mind, Sue, when I first started doing this in a demonstration project called Medicare Plus Choices, where a group of providers without a health plan was taking full risk on 35,000 Medicare beneficiaries in the early 1990s. Our care management systems were voicemail boxes on our health system voicemail system, where we would give a patient a scale to weigh themselves who had heart failure. They would every day put their weight into the voicemail box, and then a nurse would check the voicemail box. And so when you want to talk about fragmentation and inability to integrate all of the information, we continue to progress. And the timing is right. On the provider side, where I do a lot of my advisory work right now, they're looking at very significant capacity issues. So the need to develop hospital at home programs to actually extend remote patient monitoring capabilities into the home, into the workplace, produces significant amount of logistical challenges as well as data integration capabilities. And our traditional way in care management on the provider side is to throw labor at these problems, but we're running out of case managers. And so increasingly, anything that allows us to scale human capital in either the gathering of information, basically providing actionable insights at the point of intervention by a care manager, has extraordinarily tremendous value right now. So the system, certainly the GARTNER framework, segments that and puts that in place. What I would add to that is this increasing impact on the workforce. This need to make sure that where there's a shortage of workers right now that can move into this space, that we have them practicing it to the top of their ability, that they have the types of flexible schedules that they need, that they're very satisfied with their work, and that we're reducing the burnout and attrition that very significantly. Obviously, the pandemic is impacting part of this, but this is an ongoing challenge. And so I think that's another dimension of performance that the solution you're recommending can be beneficial.
That makes a ton of sense.
And David, I'm so impressed with your long-term perspective. We've come a long ways from the voicemail box to the fax machine, but we're still stuck in some of these technologies. And I just want to add that in your current work, you're actually not just looking at this from a domestic point of view, but an international point of view with the clients that you're working with. Is the U.S. behind or ahead?
It depends on the dimension that we're talking about. There is no doubt that in systems that have highly centralized decision making in their healthcare services, there are certain activities that actually can go faster. But they're the same types of, what is universal is the same types of resource limitations with manpower right now. That's a very consistent theme, whether we're looking at the UK or we're looking at Australia or almost any OECD nation where they have aging populations, a shortage of healthcare workers, and certainly in emerging countries where they can actually what I'll call leapfrog certain levels of evolution. We are seeing digital technologies applied, very, very actively and very, very quickly. And so, in that sense, I think there are some learnings that we can have in the United States in the use of digital technologies, and we do see emerging nations having to do it simply because they have growing middle classes, they have who want and demand more healthcare service, shortage of healthcare workers, and the ability to innovate in what we would consider maybe some non-traditional ways.
Terrific. Well, we'll get time for a Q&A, and I want to encourage those that are on to put questions or insights into the Q&A box, and Sue and David will deal with those. I'll monitor that. I also wanted to say, Sue, because we're going to ask Sue to give us talk us through an example of using a technology platform to do this. But I've loved from the beginning with your organization, Sue, the name HELIOS, because you've mentioned closed loop, you've mentioned 360 degree, and it's kind of the symbol of the medical profession, the double HELIOS symbol. It's there, so very creative there. But talk us through what and how and challenges of a platform that would meet those criteria that you set out for intelligent technology for care management.
Yeah, I would be very pleased to do that. So I'm going to walk you through some slides. And to your point, Ferris, the name of the platform I'm going to talk about is HELIOS. So I mentioned I'm with VirtualHealth. HELIOS is our platform that we brought to the market, and we've been in business since 2012, by the way, but we brought it to the market specifically focused on value-based care. So even back in 2012, that was the mission, that was the purpose of the company. Our CEO and founder, Adam Sabloff, believed wholeheartedly that this was needed in healthcare. And so he took that as his mission to try to bring something to the industry, right, that would really focus in on the patients and the members in their community and making a difference in a number of ways. One, around efficiency and productivity, but probably most importantly around improving those health outcomes at lower cost. So that's been the mission since we started, in our vision of having a really proactive, intelligent care management platform for the industry to take advantage of. So this diagram is something that we show a lot. H over the middle stands for the platform, HELIOS. The person in the middle, of course, is the member, the patient. And the idea is, as I mentioned before, that a key piece of any technology like this is around bringing in all the appropriate data, whether it be clinical, whether it be community information, whether it be ADL information, devices, resources, etc. All of that critical to the organizations and for them, their care teams, to really be able to do what they need to do to ensure that that patient or member has the best experience that they can. And the way that we've designed the HELIOS platform is that we view it as the daily workbench for the care team, and the care managers, clinicians, coordinators, etc. Whoever our clients want to use this platform. The idea is that they have all the information at their fingertips, right? And then there is associated workflow to help them understand and guide them to what's the right thing to do for the right member at the right time, based on their own business rules and their own model of care. So the associated workflow that's part of the platform is tailored for each and every one of our clients. And that's a really important piece. It's not, a virtual health care model. It is each and every one of our clients' care model that makes the most sense for their business. And so I think that's a really important piece of this kind of technology, is being able to have that flexibility to allow that to occur. I keep moving. This is a case study. And this is a case study that's really focused in on that efficiency and productivity we talked about. And to Dr. DiLoreto's point around manpower, right, and staffing, it's challenging. And so one of the things that our platform does is, and this is a picture of this before and after image, that one of our clients, a 2 million member plan, was able to improve the efficiency and productivity of their care management team by over 85%. So they did this case study, and that's the numbers they came up with. So, how does that happen? How does that kind of improvement occur? And if you look at this next slide, you'll see that this is kind of the behind the scenes picture of what that was. So this is an example of the RPA, that robotic process automation, the statistics around there that I mentioned. So you can see that in the month of April, in this slide, that we executed over 42 million rules automatically. So the system, based on those business rules and associated workflow I was mentioning, automatically, based on data and events that were happening within the system, automatically executed those rules. And when that execution happened, we were able to have productivity savings for the team of over 106 hours. We did the math, and that was an improvement of over 92% from a efficiency and productivity stand. So that's the kind of impact that the system can have on an organization, and really allow them to maximize the use of their care team, to be able to take on more populations, and to make sure that they are focused on the tasks that are most important to them to improve those health outcomes. So a really important part and a key part of that ROI. Another key part that we like to talk about, because I think it's really important, and I've mentioned it already, it's that tailoring of the platform. Well, how do we do that, right? We do that through configuration. We do not do that through development or customization, which would require development and programmers and all of that. Instead, this configuration and this configurability is done on the front end through one of our portals, which is called an admin portal. That admin portal allows each of our clients to come in and make this system their own. Examples of that are department names, roles, access levels, cohorts, plan names, waiver types, all of those things and many, many more are configured by the clients in our admin portal. And so that gives them that ability to make sure that this platform is truly theirs. And in conjunction with that, we have template builders that allow them to create their own assessments, their own correspondence, etc. Again, that whole tailoring idea so that this is works perfectly within their organization. And right along with that, of course, are the business rules and associated workflow that drive that RPA I just mentioned. Those are configured as well in the admin portal. So that flexibility really allows our clients to take their model of care and really maximize it and maximize the efficiency of it. This particular screen is one of the screens of our platform. I love to show this. And the reason is because the care team gets very excited about the clean look and feel of the platform. As you can see, one-click navigation, very clean look, information up front, modal windows that will pop up, and quick links that will allow clients to jump to different parts of the platform that they need to see, as well as configurable search filters, making sure that each of our clients have the information they need and the search capabilities that they need for their team to be efficient and productive. So, and we love to do demos for this same reason. People fall in love with the platform because of that ease of use. So when I think about an intelligent care management platform, I think about a few key things. One, that it has all the functionality and features that are needed across a client's needs. So is it care management? Is it care coordination? Is it UM? Is it behavioral health, workflow, etc.? All of those things being part of the system feature and function wise, but that those features and functions can be turned on and off as needed by the client. That's number one. Number two, it's that configurability I talked about, being able to tailor it just to what you need. Number three, it's that RPA, the ability to drive intelligence through the platform to the care team, so they are really guided as to what's the right thing, what's the most important thing, and the most impactful thing that can be done based on all sorts of rules, could be risk, etc. And then, the next one is that interoperability, making sure that all the information that's needed be part of the platform. And then finally, it's that usability, that making it so intuitive and user-friendly that the teams want to be using it and find it very easy to navigate. They're not intimidated by the technology. And the last point I want to make that I think is also very important is that ability to extend out into the community and where people are in their homes and being able to provide them the things that they need, whether it be a video conference or it be delivery of medication or it be delivery of diagnostic tests or DME supplies, but allowing through a platform like this, those kind of capabilities so that you can try to maximize the health outcomes and not have someone who, I couldn't get my prescription refilled, so therefore, I now have to go to the emergency room, or I didn't have DME supplies and that really impacted me. So those kind of things can extend this platform beyond the traditional, hey, care management, let me make sure I'm doing my assessments and care planning, into something that's really impactful from that value-based care perspective. So sorry about that. I'm going the wrong way. I did want to hit this slide one more time. And as you would expect, right? I think that if you look at what Gartner is saying is the Gen 3 type of solution, HELIOS, our platform does check the boxes on each and every one of these. And we take a lot of pride in that because we think that this kind of a platform is really key to helping the healthcare industry really bring those costs down and bring up the level of care to individuals.
Sue,
I hope that was helpful.
Sue, I feel like I've just taken a drink out of the future, and it's a fire hose future. And you may want to toggle back and forth. We do want to go in some questions. We've had a few come in. I want to encourage everyone to put in more questions, and we may toggle back and forth between that GARTNER checklist of functionality as we deal with these questions, because I think it's good to put a benchmark up there. And perhaps coming back to you again, Dr. DiLoreto, if we go back to that checklist wouldn't have looked the same in 1990 when you were in the front line of care management. Any thoughts or comments about the types of platforms that can facilitate this and the technology that you're seeing that hits these key points? You're on mute.
Now, as you mentioned earlier, we're much more focused in the sick care world on a transactional basis back in those days, but increasingly now the understanding of the impact of social determinants of health, the issues of health equity that are so important now to recognize and address are at the sort of at the top of providers' minds. These are things that historically have obviously been there, but we didn't have the tools, in many cases not the incentives or realization of the importance in addressing them. And so we're at a stage now where folks are looking, they may actually be able to look at their data sets, they can identify individuals who are at risk for the impact of social determinants of health, and they can see health equity gaps, but the ability to respond is actually still fragmented for many health systems. So the fact that this system has the ability to bring in folks from the community are going to be essential to addressing that, to make sure that we can track the interactions, that that they're being recognized for the value that's being created because the data is transparent and it's accessible to all of the individuals who are now contributing to whole person health, is actually a very big step forward, and something that increasingly on the provider and the health plan side will be of greater importance.
Terrific, and thanks for the questions. It seems like an HCEG group getting together. Dolph, one of our past HCEG board members, has asked the question of the two of you. A large portion of Medicare STARS ratings are now driven by patient satisfaction scores. Can each of the panelists discuss how they see the new technology assisting in recording the patient's satisfaction levels during each unique interaction with their care management personnel or interaction with the technology? Good question, Dolph.
It is. Hey, Dolph. I'm glad you're on. I'll take a first cut at it from my perspective, and Dr. DiLoreto, you maybe can go after. But my answer to that would be, Dolph, that what we do is try to engage the members and the patients right where they're at. So we have a mobile app as well as a member portal, and so using both of those mediums, if you will, we're able to quite simply do a couple things. One, they can take a survey right there on either their mobile app or their portal. Take a survey as far as satisfaction goes. That's one approach. The other approach, of course, is that there is communication and interaction capabilities real time with the members. So you can do texting, you can do chats, you can do video conferencing, etc. And so you can see how a member or patient is feeling in the moment. So there's the surveys, and then there's actually that real-time interaction. And then, of course, secure messaging on the platform, too, so that you can make sure that you're responsive to the members as they may have questions, etc. So that's how I would answer that. That's how we are typically rating it and kind of keeping track of how members or patients are feeling and how their experience with the platform is going.
And for all of the audience's benefit, it isn't just the STARS rating in Medicare, but qualified health plans in the commercial market, in the individual exchange, have to stack up against patient satisfaction measurements. And I would expand the question Dr. DiLoreto, for your comments to not just be patient satisfaction, but what about provider satisfaction?
Yeah, there's both for sure. And, you know, I won't talk to the, because Sue's done such a great job of talking to the capabilities of HELIOS and actually addressing patient satisfaction. But on the provider side, what we do know that the challenges in getting access to information, the hassles in getting to the right place for care or getting care delivered in the right way at the right time are great dissatisfiers for patients. And so anything that eliminates the fragmentation, that provides an experience in the digital world is very similar to, let's say, the experience that patients and families will have in the retail digital world or in the information exchange in the digital space is extraordinarily important. Again, from the provider side, very, very similarly, anything that actually makes it easy to do the right thing quickly and makes it hard to do the wrong thing has, significant impact. And often, as in my work, where we're working with, let's say, a med tech vendor or a vendor looking at go-to-market solutions into an integrated delivery system, a lot of the particularly from a clinician standpoint, a lot of the scrutiny is going to be exactly on what does it mean for me and my workflow? What am I going to do different when I have this versus what I have in my current state? And there's a high degree of scrutiny around those two things, workflow improvement and something that in fact is actually going to change what I was going to do. And we've seen that very consistently in whether it's med tech products or care management products as they're being brought in, or any clinical information technology. Those are the two things that are on top of providers' minds. And to your point, that fourth dimension of provider satisfaction is increasingly important, again, for the workforce attrition and burnout issues that we mentioned previously.
And I'm glad you brought that up, Dr. DiLoreto. Any of us that are in the healthcare space know that if something is going to work in the integrated delivery system, it has to fit into the provider's workflow. The EHRs have proven that, if you have to go outside of the workflow, and it's getting better to get back into the workflow, it's going to struggle or fail. And I think to the question that Dolph raised, it's equally as important, and we tend to forget about this. We're all consumers of healthcare, but we put on our corporate hat and we forget that healthcare needs to fit into the patient's, I call it life flow. And, if you're a diabetic, you're not living as a diabetic. You're living your life. You have children, you have family, you have work, you have community, you have personal commitments, you have passions and hobbies. And if what we do, even for STARS ratings, to collect that information doesn't fit in comfortably, as you said, Sue, to their life flow, I'm in the mobile app. That's the time to collect the information. How are we doing? What is it? And meeting the member where they're at with what they want. Now, the complications, and it's almost back to the future, are, we've gone from doctor visits at home 50, 60, 70 years ago to now you have to go to the doctor's office to get medical care, and COVID hits. And suddenly we have to try different models, but now, and you mentioned it, Dr. DiLoreto, home care. They're going to come into my home, remote patient monitoring, all of the data that's being, my Fitbit, my device that I'm wearing, my Apple phone that I'm wearing on my arm. All of that data needs to be at not just the patient's fingertips, but the provider's fingertips and the health plan's fingertips to be successful. I'm seeing a couple of other questions, and sorry about the narrative, but yeah, Steve has reminded us that everybody will receive the the slides and the reference material, but here's a question that has come up, and it's a little more specific. How are the community-based organizations brought in as part of this solution, and especially on the technology side? Sue and Dr. DiLoreto, you know, they may not have the same resources that other organizations might have. Any perspectives on that question from the two of you?
Yeah, you're exactly right. I'm working with some vendors now in the non-emergent medical transportation business along those lines, because during the pandemic, you know, their core businesses were disrupted because patients weren't visiting physicians, and so they began to look at how they could address other social determinants of health besides transportation difficulties, whether it was food delivery or pharmacy distribution. And what you know, the challenge is, as you mentioned, when there's a plethora of community resources to use. And by the way, providers tend to like to use local resources. You know, quite honestly, the intimacy of a health system with other community providers in their community is very, very strong. And so even if there's efficiency to be gained by using let's say a national vendor, they'll tend to want to default to local community resources. And so a platform, for instance, that makes that easy to do that could track the contractual relationships, can actually see where requests are fulfilled or not and what has happened, and makes that data interchange between the provider and the community resource, or the health plan and provider and community resource, easier, reduces that disparity that the smaller organization has. That's a very low cost way for them to actually enter into a network, and so I like that feature quite a bit in HELIOS.
Sue?
Yeah, just to expand on that. Yeah, I happen to love that feature as well. I think it's a really important one. And with HELIOS, what we'll do is, you know, we've got a variety of ways to get to the CBOs, and it depends on their preference. So some that are, you know, smaller mom and pop shops, if you will, they won't necessarily have the technology to be able to do an integration, for example. So instead, we'll give them a role on the platform. And the access is role-based access control. So based on their role, and let's pick somebody like a transportation provider, they will have a role on the platform as transportation provider, and they'll see requests for pickup for their organization, and they can fulfill those requests, but that's it. So in that way, we can bring in all sorts of different community organizations to the platform to participate as part of that extended care team, but to only see the appropriate data, and they have the appropriate tools to do what they need to do. In addition to that, from a CBO perspective, we've got partnerships with folks like Unite Us and Aunt Bertha, who are tied into CBOs, and in many cases can do closed loop, which I think, again, is key. So having the ability to send a referral through those organizations to the appropriate CBO, and then getting the information back that that service was actually done. And having that ability to see that information within the HELIOS platform about the closed loop approach on the social needs side is really critical. So typically that's how we bring in CBOs, either through a direct user in with a role on the platform, or through those partnerships with Unite Us, Aunt Bertha, etc.
So implied in the discussion to this point, and triggered in my mind with your response to that question that came in, Sue, there's a constant debate. You know, is this the provider's responsibility? Is this, you know, or is it the health plan's responsibility? And what I hear you saying, and just to be blunt, this is something that the health plan needs to step up to the plate and become that trusted coordinator of information. Am I hearing you right?
Well, we do think that makes a lot of sense for the industry, and we're seeing it play out in different states. But it's actually a coordinated effort, right, between the health plans, the providers, the delegated entity, and the community-based organizations. All of them working together, and that's the beauty in my mind of that interdisciplinary or integrated care team that involves organizations and people that maybe you wouldn't normally think would be part of, in this case, a payer solution, let's say, but they're important pieces to make sure that, the outcome is what we all want it to be. So yeah, I do think that, a plan can take this on and can, and have that visibility as well as that impact out into the community.
Terrific. So here's a question. I think it's referring back to your message, Sue, but both Sue and Dr. DiLoreto comment on this. You talked about configuration up front, but as the question is, how can the platform flex with an organization as it evolves and changes its care model, as we move from fee-for-service to value-based reimbursement? How does the platform accommodate for that?
So I can answer that one from my perspective, and it is really about that configurability that you just mentioned. That allows the flexibility. So what we see is that clients will use the platform for, let's say, a specific line of business, and maybe they then enter into another line of business or want to move additional population over. The platform can flex in that way by just adding additional rules, business rules, and then associated workflow. And in that same way, if they're moving more from fee-for-service to actually risk-based contracting or value-based arrangements, again, going in through that admin portal, through that configurability capabilities, they can modify, and they can do it themselves, modify the platform to do what they now need it to do based on the new realities of the business. So that's why it's, that's a really important part as well. It's not stagnant. This is what you get and it's always the same. You can make it your own and change it over time based on that configurability.
Any additional observations, Dr. DiLoreto? Did Sue nail it? So you're on mute, Dr. D.
Makes so much sense to have that flexibility as strategies and initiatives change to be able to do that.
Yeah, absolutely. Another question that's come in here, and I know we don't have to go the full hour, but we want to be sure that we address all of the questions. And I'm going to tweak this one a little bit. You had used a term that is a little bit foreign, Sue, to the healthcare industry, and I think you said real time. Guilty as accused, but the question is, how do platforms like this incorporate things like data into the workflow? Because we're not used to real time. And yet, if you're a provider in the hospital situation dealing with a patient and there's real-time intervention, how does real-time happen? How does the data flow?
Yeah, it goes back to the interoperability, right? And so having, and where the feature set is at. So, we can do bidirectional integrations with EMRs as an example of data flowing in real time, sending information back and forth. We have a provider portal, another example of this, where, authorizations can be submitted. So the provider submits it, they're automatically on the platform, and so the nurse can start review. And then the approval would come, and if, right, auto approval is set up in the business rules, would affect that particular auth, then and very much near real time, that would be auto approved and they would move forward. So the whole idea of the real time and getting to that is dependent on having data in real time, obviously. But we're getting closer and closer to that. We've got clients and organizations where that is a key focus, not only on auth or community resources or referrals, but also on claims data, bringing claims data in real time. And so different kind of a lens on that one, but I still think the point is that once we have the data where it's flowing basically automatically from the orienting system or the originating system to us and vice versa, we sharing information back to that origin system, it's going to matter as far as being able to hit and I'll say another word, right, proactive. So the real time is tied to the proactive. If you can do things more in real time, then you can be much more proactive in really affecting care.
So another question, Paul, it looks like is put in a kind of a tough question. Who owns the data? Not that that's a new question for any of us, but
Yeah.
is it a profile package able and portable if needed? Is the data flow, is there some portability? And Dr. D, who owns the data? We need your
I was going to ask you about the data use agreements at HELIOS.
Yeah. So, a lot of the data that we have, it comes from our clients, right? And so they have data use agreements with the originating data. So whether it's from their provider groups, their EMR systems, they're going to have that. All the data on our platform, from our perspective, is owned by our client. But our client has those data use agreements with the appropriate people, if that makes sense.
It does, and I apologize. I think that was Michael that asked that question. Again, another good colleague of ours. So one last question here, at least that's come in, unless more come in. And let me see if I can word it right. It goes back to the topic you brought up, Dr. DiLoreto, and that is the workforce burnout. How do these platforms and do these platforms help reduce the workforce burnout? And if so, how?
Well, I think, again, Sue can step in on the attributes and functionality, but obviously the robotic process capabilities of the system are extraordinarily beneficial. You're automating functions that elevate a care manager or a care coordinator into a higher level of functioning. And that's why that productivity could increase in the case study that we saw. And that's not by chance. That is not by chance, and shows the power of the system, basically to not only improve productivity, but the satisfaction of care managers or now and care coordinators functioning at a higher level. Is one of the features of job satisfaction that reduces the risk of burnout and improves attrition, or reduces attrition.
Terrific, and we're getting compliments on the experience and expertise that both of you are sharing, but it came with a question regarding risk score optimization. Is there a way to delineate which HCC codes for a specific member population would yield improvements in risk score accuracy if during the gap and chasing, I clicked the wrong button. Improving the gaps, are we going after the right gaps to close using the right method? In-home, ER, primary care visit. Today, everyone goes after the big hit codes. However, I feel it's dependent upon the health of the population being analyzed so as to intelligently, using our word, do that through data insights and technology. Any comments?
Mm-hmm.
It's a long question. I murdered it, but I'll let the two of you who see it as well answer.
Yeah, so I'll start. So from, again, my perspective and with the platform, that risk score optimization is critical, right? And a lot of things can factor in. We have some risk scores on the platform that are standard, but we'll also bring in our clients' risk scores and risk algorithms so that they have, what was most important to them. So we have one client who has, I believe, 5 scores that they bring into the platform for different areas of impactability. So those, I don't think it's one set answer. I think it varies from client to client and from our perspective. But from what we're trying to do with the platform is to leverage that risk. And to your point about, what's the severity of this person's health? How does that factor in? And then leveraging those insights based on the platform's intelligence and, leveraging AI to some degree to determine who are the people that we can most impact in a positive way, so that those are the ones that we're really that the care team focuses on, because those are the ones that they're going to be able to help the most. So that's how we look at it from a platform perspective, and then we try to provide that data to the care team so that they can act upon it.
Terrific.
Yeah, behind the questioner's comments and ask is really looking for a better framework for actually, assessing risk. And so again, this the ability to aggregate this information, increases that likelihood of being able to look at new ways of scoring, at making sure that populations who in our current methods may be underrepresented or not getting looked at because we're chasing certain HCCs, is really going to be improved by aggregating information in this way and making it more transparent for more participants in the ecosystem.
Terrific. I know we're coming up to the top of the hour and we want to be on time. Sue and Dr. DiLoreto, first of all, thank you. But in closing, any final comments? Summary comments?
Well, I'm just so grateful to see how the industry is evolving and in the right way for patients and families, and want to wish folks like VirtualHealth actually all the advantages of moving forward and being successful.
And I'd like to first thank Dr. DiLoreto for being part of this. Your comments and your insights are extremely helpful and valuable. And Ferris, thank you for allowing us to do this webinar. I'm excited about the industry and where the industry can move together. I mean, we believe that we can really help a lot of clients move forward. But I'm just excited in general about the awareness and the view around value-based care and what it can really do for our population. So I'm looking forward to what the future brings to us and how far we can take this.
Thank you. And just a couple of closing comments. We haven't said much about HCEG. We're a national network of executives and industry thought leaders, been around for 33 years, and our mission is guiding healthcare executives through innovation, change, and growth. And VirtualHealth is certainly pushing us out onto the edge of that, and we greatly appreciate it, and appreciate you, Dr. DiLoreto, as one of our board members. Your advice is constantly helpful. We interact across multiple channels, as you see here, with webinars and focus area roundtables and industry pulse research and reports and newsletters. By facilitating that interaction, which is all virtual at this point, given COVID, we provide a network for getting to know each other and information sharing and thought leadership. So don't hesitate to join us on any of these dimensions. You're always welcome. And for all of you that got on today to this panel discussion, we greatly appreciate your interest. Great questions. Some of the best questions that I've seen come in a webinar on this topic for a long time. So thank to you as participants, and you, Sue, and Dr. DiLoreto for your participation. And we wish you a very good day and all the success in care management in moving healthcare forward. Thank you.
Thank you. Bye-bye.
Thank you. Bye-bye.